think you've confirmed if I'm audible enough, but maybe if everyone else can be able to confirm the same.
Yes, you're very audible.
All right. Now, today's presentation is on renal function tests, and we want to understand a little bit about it. I know that we are all doing these tests in our labs as routine procedures, or maybe some labs have them as specialized, as Bruce has pointed out. So during the presentation on LFTs, I think it was necessary that we complete it with the renal function test so that we may be able to understand and also advise necessarily when we get inquiries regarding these tests in our labs. Now, direct to the objectives, I think we're going to look at the anatomy of the kidney and also its structure and its function. That's the physiology. I usually have a pen here, so we shall look at these two independently. I'll not measure so much on microanatomy or histology. That one is beyond the scope of this presentation. And then we'll be able to classify renal function tests, then highlight clinical utility of renal function tests as we move along the individual tests as we look at them. Now, renal function test. When you hear about renal function test, only one thing needs to come in mind, and this is the nephron. The nephron is the structural and the functional unit of the kidneys, and this is its structure, and basically it is what helps the kidney to do its functions as we know them, both the excretion of wastes and also the absorption of important materials that we'll be able to look at. And that nephron has what we call the cortex here, and it also has what we call the medulla here. So the cortex is where now this structure, including the proximal convoluted tubule here, the Bowman's capsule, which is the renal capsule. It's also called the Bowman's capsule, and the arterioles, the afferent and the efferent arterioles. We have the ducts. We have another nephron here. So this one is one unit, another one here, and there's so many others like this one's present in our kidneys. So this is basically the structure of these particular nephrons, and I need us to keep it in mind as we look at the renal function tests, because each and every section of the nephron has its own role. Like for example, this is the proximal convoluted tubule, that is this color here. Then we have the thin descending loop of Renal. Then we have the thin ascending loop of Renal. Then there is the thick ascending loop of Renal here. Then there is the distal convoluted tubules. They're convoluted. You can see that they're not straight, they're convoluted. And then there is this collecting tubule, which empties into the collecting duct. And now this duct has a lot of other nephrons emptying into it, these branches here. So this is basically the structure of the nephron, and materials will come in via the afferent arteriole here, get into the Bowman's capsule, and then now leak into the renal tubule here, starting from the proximal convoluted tubule, going all the way this way until they empty this way. So that's the movement of materials. Once the material have been cleared or they have been sieved, then they'll exit the Bowman's capsule, this particular structure, the Bowman's capsule, through the afferent arteriole, which will now be able to divide into the peritubular capillaries that will be able to collect materials after reabsorption. So that's basically the function, the setup. And as we look at the function, the individual tests, we shall know where they are getting reabsorbed, cleared, and all those kind of information from the presentation. Now, in the anatomy, each kidney, of course, has over 1 million nephrons, which are the basic function and basic functional structures that are made of the glomerulus. That structure, which contains the a tuft of capillaries that are surrounded by the Bowman's capsule. And then each is supplied by an efferent arteriole carrying blood in and an efferent arteriole carrying blood away from the glomerulus. Then the efferent arteriole branches into the peritubular capillaries. These ones that supply the tubules. And we shall be able to look at how this happens by the countercurrent, exchange of materials along the loop of Renal. Then the proximal convoluted tubule is located in the cortex, as we've seen. Then there is the long loop of Renal, which is composed of a thin descending. Then it spans the medulla and an ascending limb, which is thin and then thick, which is located both in the medulla and the cortex. And of course, is composed of those particular segments, thin and thick. Then the distal convoluted tubule is located in the cortex entirely. Then the collecting duct that's formed by two or more distal convoluted tubules that merge and empty their contents into the renal pelvis. So that's basically the structure. And on the physiology, the function, the nephron does a lot of filtration and reabsorption of materials. So filtration depends on the high pressure in the blood, which is the difference in pressure between the afferent and the efferent arterioles, and then the negative charge at the basement membrane, and then the semi-permeable nature of the basement membrane as well. And it produces around 125 to 130 mils of filtrate out of the 1200 to 1500 mils of blood that is received per minute, which is actually the glomerular filtration rate. Now, on the absorption, proximal convoluted tubule has a lot of reabsorption taking place, including water, around 75% of water, sodium and chloride, and 100% of glucose, which is, reabsorbed up to the level at which the renal threshold is reached, or up to the level within which the kidney can be able to absorb this glucose, beyond which we shall have glucose in urine. Then amino acids, vitamins, proteins, and urea and uric acid, ions such as magnesium, calcium, phosphorus, and bicarbonate are all reabsorbed at the proximal convoluted tubule. Now, we shall only see these things in urine if this particular function is impaired. Then almost 98 or the entire uric acid is actively reabsorbed, and only a small amount is secreted at the end of the proximal convoluted tubule. Now we know that substance movement from tubular lumen to the peritubular capillaries happens through the differences in the concentration gradients, and it is either active or passive. And active involves the use of ATP or energy against the concentration gradients, with the exception of chloride and water, which happens passively during the sodium exchange. When sodium is being pumped in and out of the capillaries, then these ones happen alongside, like they're carried along through those particular exchanges. Then tubular secretion at the proximal convoluted tubule, we have the movement of substances from the peritubular capillary plasma to tubular lumen, which can also be passively or actively. Passive means that there is no use of energy. It is along the concentration gradient, but active means that this is happening against the concentration gradient, and it will need an energy to be facilitated in terms of in form of ATP. Then, of course, there's this term renal threshold, which is the plasma concentration above which substances appear in urine, right, like that. So the countercurrent multiplier system along the loop of Renal, this is the opposing flow in the loop, which is the downward flow in the descending loop and the upward flow in the ascending loop. And we saw the structure. And the osmolality in the medulla in this portion of the nephron, of course, increases steadily from the corticomedullary junction inward and facilitate the reabsorption of water, sodium, and chloride as it happens along the loop of Renal. Sodium and chloride are actively and passively reabsorbed in the medulla and of interstitial fluid along the entire length of the limb. Then the descending limb is relatively impermeable to water. And then the ascending limb becomes hypotonic because there is now water permeability through the action of hormones that control the water homeostasis in the kidneys. And the chloride ions are reabsorbed without their loss, so that this hypotonic solution is now hypotonic fluid is now released um, uh, as urine, which will be also concentrated again depending on the amount of this particular solutes, sodium and others like urea in the blood. Now, the descending limb is highly permeable to water and does not reabsorb sodium and chloride. And the interstitial hyperosmolality is maintained because of the ascending limb, because the ascending limb, of course, continues to pump sodium chloride ions into it. So that's the hyposmolar maintenance. At the farthest end, where there is the distal convoluted tubule, of course, it's shorter than the proximal tubule with 2 or 3 coils that connect to a collecting duct and affects small adjustments to, effects are small adjustments to achieve electrolyte and acid best homeostasis via these hormones here, ADH, which is the vasopressin, or this is the antidiuretic hormone, or also called vasopressin, and it's secreted from the posterior pituitary gland. Aldosterone controls aldosterone controls the also the control of sodium in the kidneys. It senses whether it's too high or too low, and affects the feedback mechanisms to correct the values or the levels. And also through the RAS, or the renin angiotensin aldosterone system. So all these things are put together in the RAS system, which is a negative and positive feedback mechanism. We should be able to look at it. Now, secretion is triggered by decreased blood flow or blood pressure in the afferent renal arteriole, and decreased by plasma sodium. So sodium metabolism and sodium balance happens. If it's too much, then the hormone aldosterone is created to control its secretion or reabsorption, like that. Then ADH stimulates water reabsorption. Aldosterone works on sodium, as I mentioned, and other ions now move along that particular control as passive molecules, because when you're controlling sodium, then you're controlling chloride in passively. Hydrogen ion secretion is due to bicarbonate regeneration and ammonia secretion, and it occurs at the distal convoluted tubule. This is the control of hydrogen ions, and they are actively reacting with the bicarbonates to form hydrogen bicarbonate, which is converted back and forth depending on the concentration of either of the reactants or the products of that particular reaction, which we shall be able to look at. I wanted to mention some special cells or structures of the kidneys or the nephron before we go to the individual functions. We have the mesangial cells, which provide structural support and regulate blood flow, filtration, and also work as an immune, protection against infections in the nephron. Then the podocytes, which are on the visceral layer of the glomerular capillaries, and they interdigitate, like they interdigitate to allow for selective filtration of molecules. Interdigitating means that they are interlocking and they are leaving some spaces for small molecules to pass through. Then there is the macula densa, which is also at the distal convoluted tubule and senses the sodium levels and help in blood pressure regulation through the hormones that are involved in the distal convoluted tubule. Now, the collecting duct is the final site for either concentrating or diluting urine under ADH or aldosterone hormones. And urea diffuses down its gradient out of the tubule into the medulla and increasing its osmolality. So more of urea is again reabsorbed back into the system at the collecting duct. So the kidney has a lot of capabilities to control urea, to excrete urea, and dysfunction happens only when more than 50% of the kidney has been, damaged. That's when we shall be able to start seeing a lot of urea accumulating in the body, and we can be able to measure for that and tell whether it's normal or not through the urea tests or urea levels. Then, on a brief mention of the renal functions, these are the functions, mainly the excretion of metabolic waste, and then water and electrolyte homeostasis or balance, pH homeostasis or balance, through the control of the hydrogen ions by the bicarbonates and the ammonium, roots, and then renin production and vitamin D regulation. So if our kidneys are not working properly, then all these ones are affected. And a person will have a multiple sort of symptoms that are tied to any of these ones here, any of the improper functionality of the kidneys. Now, mention of the renal diseases, we have the glomerular diseases that include acute glomerulonephritis, inflammation of the glomerulus, which is characterized by a rapid onset of hematuria and proteinuria. You may see this one especially for the ladies who are, expectant. You observe a lot of proteinuria, and it's just due to, those acute glomerulonephritis that happens during, pregnancy, and also due to increased permeability of that kidney to, more proteins in the system, and also due to blood pressure. A lot of things are tied to proteinuria in urine. And also now, this one is characterized by low GFR or glomerular filtration rate and high blood urea nitrogen. So it's often related to recent infections by group A, hemolytic, streptococci, and immune complexes and drug exposure that are deposited in the glomerulus. Chronic is low onset that gradually develops after some time. And it's characterized by, gradual development of uremia or urine. Urea in blood, a lot of urea accumulation in blood. This one is a characteristic of chronic glomerulonephritis. Then there is the nephrotic syndrome caused by several diseases that may result in an injury and increased permeability of the glomerular basement membrane. And there is massive proteinuria and resultant hypoalbuminemia, which leads to edema. So one thing, proteinuria is just protein in urine, and this protein is mainly albumin. So when albumin is lost in urine, then we're going to have low albumin levels in the blood, hypoalbuminemia. And when there is low albumin in blood, then we'll lose fluid into the surrounding tissues, into the surrounding, tissue fluid, and it will cause tissue swelling because there is no reabsorption of that fluid back into the circulation. And albumin is an osmotically active molecule, so when it is low, then edema will be able to arise from there. Then tubular diseases, we have renal tubular acidosis or RTA, which can be distal, in which the renal tubules are unable to keep up with the vital pH gradient between the blood and the tubular fluid. Or proximal, in which there is decreased bicarbonate absorption, resulting in hypochloremia acidosis. And acute inflammation also may occur as well in tubular diseases. So these are just kind of conditions that are affecting the tubules themselves. And acidosis is going to be particularly problematic because of improper hydrogen ion control. Now, renal obstruction is also another condition that can happen. Obstruction, physical obstruction, which may happen in two ways, either gradually, which may gradually raise the intratubular pressure until nephrons necrose, yeah, they shrink up, and which may also lead to chronic renal failure, or they may predispose to urinary tract infection, repeated in fact. Because if there is no flow of fluids, then bacteria are prone to be deposited in those areas where there is inadequate flow, and they can cause infections. Then of course they can also be caused by neoplasms or growths. These are growths, and especially in male, if we're having something like a prostate hypertrophy or maybe prostatic cancer, then it can lead to obstruction of the outlet tubules that are emptying the bladder and the kidneys themselves. There could be acquired diseases, congenital deformities of the lower urinary tract. When the deformities or those physical abnormalities, and then of course we can have obstruction. They manifest with decreased urinary concentration capability, diminished metabolic acid excretion, and then decreased GFR, or glomerular filtration rate, and reduced renal blood flow. To investigate this, you can be able to do a urinalysis, you can do a urine culture for the infection, you can do a blood urea nitrogen, which is just urea multiplied by some factor there, and then serum creatinine, and also a complete blood count if you want to do to check for the infection. So we are getting into that. And then renal diseases, of course, we have also renal calculi or kidney stones, which are most common, predominantly composed of calcium oxalate, and then they increase in dehydration. So dehydration is a risk factor. And then they're accompanied by hematuria or blood in urine, urinary tract infection, and characteristic abdominal pain, sharp pain because of these stones here. People describe it as sharp, pain that is characteristic to the renal calculi or kidney stones. I needed to mention on AKI and CKD. So AKI or acute renal failure is just sudden sharp decline in renal function as a result of an acute toxic or hypoxic insulin insult to the kidneys. And it has these features here. We have increased serum creatinine by more than 0.3 milligrams per DL from the baseline, whichever the baseline is. And then increased in serum creatinine to more than 1.5 times. This is within 48 hours. This is more than 7 days from the baseline. So if you have your normal creatinine as maybe 55 microliters per liter, then this one is increased by 1.5 times, which could be, around 70 something, 75. That's 50 times 1.5, it could be 75. Then you do it again, it's increasing like that. We have urine volume that's less than 0.5 ml per kg per hour for 6 hours. These ones are all characteristics of acute kidney injury. So you can be able to do a creatinine, and sometimes you do serial creatinine monitoring. So sometimes the doctors could be requesting for repeated creatinine levels, and they're just going to, figure out whether they are dealing with AKI through the values that you are releasing. So it's very important to be consistent so that you can give very accurate results to guide the decisions, because they're going to rely on these particular levels to classify this AKI. Then it's subdivided into 3 parts depending on the location of the precipitating defect. which could be pre-renal. Anything that's happening in the blood supply before it reaches the kidneys, pre-renal, of course. It can include cardiovascular system failure and consequent hypovolemia. So if those ones are there, you can have increased creatinine levels. And AKI. So another one is primary renal failure, which is the defect that involves the kidneys directly. And the most cause is acute tubular necrosis, the shrinkage of these tubes that are no longer allowing for adequate passage of fluids. Then vascular obstruction, inflammation, and glomerulonephritis. Then there is the postrenal failure, which is the defect that lies in the urinary tract after its exit in the kidneys. And this is after the lower urinary tract of obstruction or rupture of the urinary bladder. So anything that's happening after the blood has gone through the urinary bladder, like the kidneys. And causes may include hemolytic transfusion reactions, myoglobinuria due to rupture of muscles, rhabdomyolysis, rupture of muscle cells, and then heavy metal or solvent poisoning and drugs. So these things here can cause acute kidney injury or AKI. Then there is hypoxic insults that include conditions such as maybe severe compromise to renal blood flow, maybe too much blood loss, which will lead to inadequate, passage of that blood in the kidneys, such as hemorrhage. Of course, these are the ones that can be able to lead to compromised renal blood flow, hemorrhagic shock after someone has lost a lot of blood, or sepsis, burns, and cardiac failure. AKI is characterized by edema and it progresses to chronic renal failure if it doesn't get corrected within the right time. As defined by the modification of diet in renal disease, this one is the risk of AKI, and the first risk is an increase in creatinine to 1.5 times the baseline, which leads to, of course, a reduction in EGFR. The correlation between creatinine and EGFR is inverse. The higher the creatinine levels, the lower the glomerular filtration rate, and that way is inversely proportional. So the higher this one, the lower this one here. Then we have injury to the kidney, which results in an increase in creatinine to 2 times the baseline, and of course a reduction in glomerular filtration rate up to 50%, or urine output that's reduced to less than 0.5 mils per kg per hour for 12 hours. Then failure, which is a rise in creatinine levels up to 3 times the baseline level, and glomerular filtration reduction up to 75%. Yeah, creatinine could be even more than four times, and urine output is reduced, to less than 0.5 per mil per kg per hour for 12 hours. And then loss of kidney function, of course, over 4 weeks. If this insult is present for more than 4 weeks. Then we have end-stage renal disease, which is complete loss of renal function for over 3 months. So this is the progression of AKI into those complicated forms of ESRD or end-stage kidney disease that may need now transplantation or maybe someone to be put on hemodialysis. Now, CKD here is a clinical syndrome that occurs when there is a gradual decline in renal function over time. And the epidemiological data shows that 1 in 9 adults in the USA has CKD, yeah, and 20 million more people are at risk. This one is way, way too high. Yeah, this is way, way too high. And people are having these particular conditions, especially in those particular developed countries. And there are 5 stages of CKD based on risk factors and, of course, glomerular filtration rates and the damage to the kidney membranes that are used for filtering the substances, the waste products. And also will lead to increased proteinuria or microalbumin in urine. Now, the first stage here, normal GFR is above 90, right? Above 90. And the first stage is kidney damage with normal or around normal GFR, which is around 90 there. The second one is kidney damage with normal EGFR or reduced EGFR, which means that creatinine is increasing. And this could be 60 to 89. Moderate with reduced GFR, and this GFR could be between 30 to 59. Severe with reduced GFR of 15 to 29. Then kidney failure is actually a GFR of less than 15. We can be deriving these GFRs during our renal function tests. You do your creatinine. There are formulas all online that can be able to help us derive this and release the renal function test as a complete profile. When someone pops on or looks at it, they can be able to see this one already calculated, and it makes work very easy for those people who are interpreting the report. Now, CKD can cause a lot of things, and we can see this diagram here that is trying to explain the entire process. We can have it affecting, because of chronic renal failure, we can have loss of the endocrine function of the kidney, which leads to loss of erythropoietin. Erythropoietin is a hormone that is involved in erythrocytes, erythrocytopoiesis, or formation of red blood cells. And if this one is lost, then we shall have anemia. We can also have a failure of conversion of vitamin D into either dihydrovitamin D, that's the one that is usually active, and this leads to hypocalcemia, and hypocalcemia leads to hyperparathyroidism or hyperfunctionality of this thyroid gland, and it leads to bone resorption to help repopulate the calcium back into the system. Chronic renal failure can also lead to failure in iron homeostasis, which can lead to a lot of sodium retention and can lead to peripheral edema, can also lead to pulmonary edema, can also lead to hypertension because of too much sodium there. It can also lead to high acidosis. It can also lead to loss of water function, which will lead to polyuria and loss of fluids now through the kidney. It can also lead to retention of toxins here, which will lead to encephalopathy or confusion, and some people also enter coma because of high concentration of waste products in their bodies, especially urea as well. And via known mechanisms, it can also lead to other things up there, which you guys may be able to look at it later. Now, the high incidence, of course, of CKD is because of other comorbidities, which we have diabetes, aging population, and obesity, and metabolic syndrome. And around 45% of these patients have type 1 diabetes. Around 45% with type 1 diabetes, of course, develop diabetic nephropathy in their lives within 15 to 20 years or after diagnosis. And diabetes affects the kidney by causing them to become glucosuric, polyuric, and oxuric, attempting to dilute the hyposmolar state of the urine, like that. It's just a feedback mechanism that the kidney is trying to control. Other risk factors are old age, above 65, and obesity. Then the metabolic syndrome that includes a lot of other things that may be accumulated in the body, including hypertension, low density lipoprotein, cholesterol level, hypertriglyceridemia, and hyperglycemia all together. These are metabolic syndrome that also lead to persistent CKD. Renal hypertension is blood pressure that involves the kidney. And here is where you can have people requesting for such things as aldosterone levels to assess the functionality of the kidney in water balance. And we can also have people requesting for renin levels to assess for the functionality of the RAS system, which is a very powerful vasoconstrictor, and it leads to renal hypertension. So sometimes you can have low fluids in the body, and they lead to activation of this system here, and it leads to retained fluid, which now is detected as high blood pressure, and there are a lot of causes for these ones here. So when these particular hormones are involved, and then it's an homeostasis kind of a situation where if there is too much water, then aldosterone is released to control that. If there is too much sodium, then we're going to have other hormones like maybe, of course, aldosterone that's going to control that, ADH that's going to control the water, and try to sort this particular renal hypertension issue through the renin and angiotensin system. Now, of course, as a result of aldosterone action, there will be increased sodium, serum sodium, and decreased serum potassium, and increased urine potassium. So if sodium is being reabsorbed back into the circulation, potassium leaks out of the circulation like that into from out of the renal tubules into the urine now, so that now we can have a lot of it being emptied and secreted in the urine. So control of sodium here controls other ions altogether. Now on the West, these are the individual tests that we normally do for the kidney functions. We have urea, and this is the normal value of urea if you're using milligrams per DL, and it makes up 75% of the non-protein nitrogen compounds. And it's produced from oxidative catabolism of proteins through the ornithine cycle in the liver. Then these proteins are, of course, broken down to release amino acids, which are deaminated to ammonia, and ammonia is really converted to urea, and to avoid toxicity, because ammonia is toxic. Then urea is ready filtered at the glomerulus, but is also reabsorbed at the collecting ducts. So that's why we normally don't do urea clearance, because this reabsorption here will be able to affect the test altogether. So we normally have urea levels only as a marker of renal function. Then increased urea levels is present in hypermetabolic conditions and starvation. And then it is decreased in hepatic injury, which means that this cycle is inadequate and is releasing very little urea, because this happens in the liver. Then measurement is via UV kinetic methods using alpha ketoglutarate as an ammonium ion acceptor or receptor in the presence of an enzyme glutamate dehydrogenase, like that. Those are the kits that we use for urea analysis. Burn is derived from urea using this formula here. You get your urea, you multiply by 0.47 if you're using mg per dl, and it is increased in intrinsic renal dysfunction, or prerenal azotemia, or prerenal, this is high urea before in those, areas before the kidney, such as congestive cardiac failure, shock, vomiting, and diarrhea. Postrenal azotemia, or high urea after the kidneys, is bilateral urethral obstruction, bladder outlet obstruction, and bladder dysfunction. So high burn can always be increased in all these conditions here. But now you correlate with the patient's history, and then you can be able to tell if this is prerenal, postrenal, or intrinsically renal. Then decreased in fluid overload or malnutrition or severe liver disease because of the ineffective ornithine cycle. And also in the syndrome of inadequate ADH production can also lead to a lot of water accumulation in the body, which will lead to decreased burn. And we can also have burn to creatinine ratio for further assessment of the renal function, which is supposed to be between 10 to 20. Creatinine is a muscle is secreted and also metabolized in the muscles, which is forms it's a it's a high energy, it's a high energy molecule that, in the form of ATP, that it's catalyzed by the CK or creatine kinase to form creatine. And further action with the ATP with no enzyme leads to creatinine levels. So sometimes you can do the CK or creatine kinase to measure the functionality of this conversion here from creatine phosphate through the utilization of adenosine diphosphate or ADP and hydrogen ions to form creatinine. And then sometimes you can do creatinine levels themselves. So if you see creatine kinase as an enzyme, just know that it's assessing this particular process of conversion of creatinine phosphate or creatine into creatinine. And its increase might now mean that there is too much of this, and it's correlated directly to this and inversely to this, to creatinine levels. Then up to 20 of the total mass of creatinine spontaneously dehydrates and cycles to form creatinine. And thus, creatinine levels are a function of muscle mass and remain approximately the same in an individual from day to day unless muscle mass or renal function changes. So creatinine is also readily filtered by the glomerulus and is not reabsorbed. That's why it's possible to do creatinine clearance, because once it has been filtered by the glomerulus, there is no reabsorption that happens in the tubules. And when you do a creatinine clearance, it's going to indicate the actual functionality of the kidney. Uric acid is also a waste product that's created after the metabolism of the purines or adenine and guanine. Then it's undergoes complex cycles of reabsorption secretion in the course of the nephron, and only around 6 to 12% of the original filtered uric acid is actually excreted in the urine. And if it is if it is highly concentrated in the system, then it is in the form of sodium urates that get deposited in the joints, to form gout, and can also form urolithiasis or the kidney stones. So if these ones are too much, and then there is dehydration, there is those deposition in the kidneys and in the joints to form urolithiasis and gout. So if you do uric acid levels, then you're going to assess those particular two. Water balance is through ADH. I'm not going to belabor on that one. And also that. So we're going to look at electrolyte balance. This one involves sodium, potassium, magnesium, calcium, and phosphorus. And sodium is the primary extracellular cation in the body and is excreted principally through the kidneys. And its balance in the body is controlled through excretion via the RAS system and the aldosterone, of course, the renin-angiotensin aldosterone system. Then potassium is intracellular and is freely filtered by the glomerulus. So, and then reabsorbed throughout the entire nephron, except the descending loop of Renal. So if you're doing sodium control or reabsorption, potassium is also going to move along that particular gradient. Opposite. If sodium is coming into the tubules, potassium is getting out of the tubules to balance the positive ions around that particular membrane, on either sides of the membrane. Then both the distal convoluted tubule and the collecting ducts can absorb and excrete potassium. And this excretion is controlled by aldosterone, the same amount that controls sodium reabsorption. Then potassium ions can compete with the hydrogen ions in exchange with sodium in the proximal convoluted tubule. And this process is used by the body to conserve hydrogen ions and thereby compensate in the states of metabolic acidosis. So instead of using excess hydrogen is used during those alkalosis to try to lower this particular pH back to normal and reverse the acidosis. Chloride is principal extracellular anion and is involved in the maintenance of extracellular fluid, readily filtered by the glomerulus, and is passively absorbed along the sodium, channels like that. Then it is in the descending loop, Potassium, of course, is highly reabsorbed by a distinct chloride pump, which also reabsorbs sodium in the loop of Renal, in the ascending loop of Renal. And this pump can also be inhibited by the loop diuretics, of course, during the control of water. And then the regulation of chloride is controlled by the same forces that regulate sodium. So I think that I've already mentioned. On phosphate ions, it has higher concentration in intracellular than extracellular fluid environment. And it exists as either protein-bound or non-protein-bound form. And hemostatic balance is chiefly determined by the proximal convoluted tubule reabsorption under the control of parathyroid hormone. This one is in conjunction with the calcium, which are all both controlled by PTH here, parathyroid hormone, and also magnesium, which is an intracellular and is an important cofactor. Also exists in both protein and ionized states, of course, or free states. And then this fraction is easily filtered by the glomerulus and it's absorbed by the tubules under the influence of parathyroid hormone. So you can be doing parathyroid hormone to assess for metabolic functionality of the kidneys. Because parathyroid hormone is directly involved in the control of metabolism, and this metabolism involves these particular ions: calcium, magnesium, and phosphorus. On acid-base balance, I think this is just maintenance of a normal, pH of the body by this particular bicarbonate system here through the action of carbonic anhydrase enzyme. And this equation can move forward or back depending on the concentration of CO2 or hydrogen ions here and this bicarbonate ions. So I'm not going to belabor on that. This is in the notes. You can be able to read on it during the view of the video on YouTube or something like that. Then this only acts to maintain the normal pH, to avert acidosis and to avert alkalosis. And it is a buffering system that exists to control that, which happens in the kidneys through the water control, sodium and bicarbonate control, and also hydrogen ion control. Ammonia is also deaminated to less, harmful products such as urea, and it's excreted in urine. And this is the process through which, ammonia is deaminated or made into a less toxic form, which is urea, and excreted. The phosphate, hydrogen phosphate is a buffer, which also controls the acid base. And this one I'm not going to belabor on it because it just happens through the control of hydrogen ions. And if there is too much of this, then the reaction can go forward and back like that. So this balance exists because of depending on the hydrogen ions. Renin also works in the control of blood pressure in the kidneys through the conversion of the inactive angiotensin to the active angiotensin 2 through ACE, and it's a vasoconstrictor that increases blood pressure. So if you see renin, it's just produced to increase renal blood pressure to control the water levels in the body. This is the system that maybe I should be able to briefly explain. We have a stimulus here, which is blood volume, and blood volume can be decreased. When it is decreased, then there is renin secretion. When renin is secreted, it leads to the conversion of angiotensin 1 to angiotensin 2, which leads to increased blood pressure. That's a response, and sorts this low blood pressure into back to normal. Angiotensin 2 can also activate aldosterone secretion in the adrenal gland to increase sodium reabsorption, which will increase sodium levels in the plasma, which will increase the osmolality of this plasma, And the hyposmolality increases water reabsorption back into the plasma and sorts the blood volume, yeah, rectifies the blood pressure. Again, we can have a stimulus here, which is high plasma osmolality, and the hypothalamus is stimulated to, send signals to the posterior pituitary to release ADH, which increases water reabsorption back into the plasma to sort the osmolality. So those are two functions that can both be encountered in the kidneys. Erythropoietin is involved in RBC production. So if there is a problem with the kidneys, then we are going to have a problem in RBCs. That's why there is anemia in those guys who are on dialysis and those chronic kidney diseases. Others are vitamin D and prostaglandins and thromboxanes that I'm not involved describing, but I want to look at creatinine clearance and maybe microalbumin as we wind up, because I've already handled most of the individual analytes in this particular presentation. So now clearance is measured by a molecule that can be fully filtered by the kidneys and never be reabsorbed back. So this is an ideal molecule that's supposed to be there to be filtered and not to be reabsorbed by the kidneys in order to give a true value of a true picture of how clearance is happening in the kidney. The closest molecule endogenously is creatinine because it doesn't get reabsorbed. But there are proposed molecules such as inulin clearance, which are exogenous, or someone can be injected with that molecule, inulin, which is completely filtered and eliminated without reabsorption in the kidneys. But because of the expenses and the complexities with inulin measurements, creatinine clearance is actually done as a routine measure of kidney clearance. Now, of course, is a nearly ideal substance for the measuring of this clearance, and it's an endogenous metabolic product that's cleared by the glomerular filtration and is not reabsorbed. So, and only a slight amount is created by the proximal convoluted tubule. So it gives a near clear picture of how well the kidneys are actually filtering the blood. So serum creatinine levels are high in males and females due to the direct correlation, of course, with muscles, because they are dependent on muscle mass. And analysis depends on colorimetric kinetic assays. So this is what I needed us to understand, that this molecule that measures clearance is supposed to be having some sort of characteristics that we have looked at there. So on clearance and glomerular filtration, calculation of creatinine clearance is the standard method for determining of glomerular filtration rate. And this is derived mathematically by relating the serum creatinine concentration to urine creatinine concentration excreted in 24 hours. That's why you need a 24-hour urine sample in this. And then the urine container that is used for this purpose is not supposed to have any preservative. It's just kept in the fridge for that period. And it's supposed to be timed very well so that we're having actually 24-hour urine collected. Then the concentration of creatinine in both serum and urine is measured. And this is the formula that is used to arrive at that particular filtration rate or the clearance level. So this is the creatinine level for urine. Then this is the plasma or the serum creatinine level, multiplied by the urine volume in 24 hours and multiplied by the 40 minutes in 24 hours, all right? Then this is the surface area for a normal human body, and you can be able to correlate it to correct it using some constant here, A, to cater for the different body masses or the surface areas for the different people. Some people are obese, others are thin, so you want to correct that so that you can have as true a value that's as true as possible to the actual clearance level of the kidney. Reference values here for males is supposed to be above 97 milliliters per minute per 173 meters squared to 137. Females are a little bit lower, of course, as a correlation to the muscle mass. And EGFR is another way of doing it using a spot sample now. For clearance is 24 hours. EGFR is using a spot sample or a sample that you just collected right there. And it only depends on the serum creatinine levels. So this is the question that is used and doesn't need urine creatinine levels. And it's affected by, gender, age, body size, and all those rest and everything. So we have 140 minus the age of the patient, and then you multiply by the weight over 72, and then times the serum creatinine levels, right? We multiply by 0.85 if this person is female. Different formulas have different constants. Like the MDRD, you'll see maybe it's using around 0.76 or something like that to get your EGFR. So if you Google around the websites, you will find the estimated glomerular filtration formulas, filtration rate formulas. We have the mixed diet in renal disease formula. We have the CKD or the chronic kidney disease epidemiology formula that are different, and you can be able to use it like that and reference your calculation to a particular formula because they are different. If you get your estimated EGFR and someone else goes to calculate it, they may get a different value and they will start calling you, whether you had done the right thing or not. But maybe they could have used a different formula. So it's usually very important for you to quote the formula that you have used in your EGFR calculation so that those calls can be avoided altogether, or the person can be able to look at it and correlate to the formula that they can be able to check and confirm the creatinine clearance or the estimated glomerular filtration rate. The last thing I wanted to mention in the renal function test is urine microalbumin, which is usually done as the urine, albumin creatinine ratio or SCR. And it is an important measurement in patients with diabetes and assesses the risk for the development of nephropathies. Now, for those ones with type 1 diabetes, they have a 30 to 45% risk. And type 2 is around 30% risk. And microalbumin's availability in the urine happens because first there is renal hypertrophy or reduction, or hypertrophy is the reduction in those particular tissues in the renal structures. Then hyperfunction, an increased thickness of the glomerular tubular basement membrane. Then after 7 to 10 years, a long time, there is progression to glomerulosclerosis with increased glomerular capillary permeability. Microalbumin is just small amounts, not small molecules of albumin, but small amounts of albumin in urine. Yeah. So this permeability allows for that albumin to seep into the filtrate, and it can now be detected in the urine. And early detection and control adverse progression to end-stage renal disease or ESRD. And measurement of microalbumin is through albumin-specific immunoassays, which usually use nephelometry or immunoturbidimetry. And we can be able to, there are even point-of-care equipment that are doing microalbumin. And then also urine creatinine levels. And then urine albumin concentration of 50 to 100 milligrams every 24 hours predictive of diabetic nephropathy. And then a 24-hour urine collection is preferred, but random urine sample can be used to determine this particular ratio of albumin and creatinine levels. And the albumin creatinine level of 20 to 30 milligrams is indicative of microalbuminuria. So this is what I wanted to mention as far as kidney functions are concerned. And I've tried to, highlight a lot of other things are there in the background. Maybe we can be able to clarify this through a session maybe of inputs from specialists or other people who are involved in this, or questions, or another interactive session as we look at the references that I used for this particular presentation. So at this particular juncture, I'd like to bring the mantle back to you, Bruce, for that particular session that's following. Thank you so much for listening in. Yes, Bruce, if you can hear me, please, you can take up the mantle from here. Bruce, are you within?
Oh, yes. Yes, I'm
Yes,
in.
please.
Sorry for that.
All right.
Thank you so much, Baraza, for that nice presentation. Okay. I can see from the comments, I can see Helen saying, thank you for the presentation. Isa Abdi, very informative. Thank you so much. Wilfred Moriasi, good presentation. Lynette Odiambo, good presentation. Okay. Now, let's tackle a few questions that I can see. I can start with the Moranga, Brian. Moranga is asking, EGFR normals, are they independent? Are they dependent with the formula? Okay. Maybe I'm not getting that question clearly.
No, yeah, I get it. I get that question very clearly. Yeah? That they are dependent on the formula that is used. Because there are different formulas for estimating glomerular filtration rate. And I mentioned that there is the modification of diet, in renal disease, or the MDRD formula. There is also the CKD-AP, or the chronic kidney disease epidemiology formula, which use different constants. So because of that, you may have different values of EGFR for people who have used different formulas. So that's why I was saying that for you to calculate EGFR in your UECs, you have to quote the formula that you have used, so that you may not have those questions coming back to you. Why are you giving us a different EGFR from what you're getting? So if you quote the formula, that question is sorted.
Okay, thank you. Topiko Memia is asking, what is the best time of the day to run renal functions? Is urine or blood the most preferred? Okay, Baraza.
I don't know whether I have a specific answer to that. Perhaps we can be able to check into the literature with the person who has asked the question himself, check up, see which is the best time to do that. I've not come across a literature describing that, but we can be able to check in, and look into that. Thank you.
Thank you. But the second part of the question is asking, is urine or blood the most preferred? So maybe you can take him through the renal functions again in summary, the specific tests for the renal functions, because I know there are a group of tests.
So a renal function is going to be having electrolytes. Standardization has happened so much in electrolytes. Yeah, not electrolytes, in serum as a sample type, right? Fluids have troubles with reference values. If you're talking about urine as a fluid, if you're talking about other fluids, there is trouble with the reference values. But the best sample for you to use is serum, because that one is highly standardized, and the measurement, The measurement modalities exist for that, which are easily available. And you may not find very many platforms that are doing urine analysis for this particular analytes. But there are some physicians that may need to do the urine, may need the analysis done in urine. You can go ahead and do that and then confirm with specific literatures for the reference values for you to be sure that you are interpreting the right way. Not to confuse the normal values for urine and that one for blood for that particular purpose of interpretation. Yeah, back to you, Bruce.
Thank you so much. Shadrach Kosgei is asking, explain proteinuria in relation to renal functions, kindly.
Proteinuria is protein in urine. So there is a protein, normally it's not supposed to seep through the basement membrane, right? Because of the nature in which it has been designed by God, right? So protein has, it's large, has large molecules, and the net charge on proteins is also repulsive against the basement membrane. So when there is damage to the basement membrane of the glomerulus, then there is seepage of the protein that's large, not supposed to be filtered through. But if there are problems with this particular filter, which is the basement membrane, then we shall have leakage of protein from the plasma or blood into the tubule. Now, when that happens, it only happens, of course, when there is, of course, a renal basement membrane damage or the damage to the glomerulus. That's when we shall be able to find protein in urine. Or if there is too much blood pressure, this blood is coming via the afferent arteriole and it's coming under a lot of pressure, high blood pressure, then protein is going not to be forced out of the seepage or out of the filtration system, now under the influence of the blood pressure itself directly. That's why we also find proteinuria in people who are having high blood pressure because of that physical exertion of pressure on the basement membrane, and ends up, having larger molecules seeping through the basement membrane into the urine sample, that you can be able to do a dipstick or maybe quantitatively determine the microalbumin levels, and that can be able to be detected in urine like that. So it depends on the integrity of the glomerulus and the basement membrane and also the blood pressure. I think if I can be able to put it like that.
Thank you so much. Another question from Fanuel Monde. When using CKD API formula, what values can you say it's too high?
There is a table that I had shown which trying to sort of interpret the EGFR. A normal EGFR is supposed to be above 90. Now, the reduction in that particular level will correlate to the severity of the EGFR of the kidney disease. So depending on how low the EGFR has reduced, and EGFR is inversely proportional to the creatinine levels in the body. So depending on how much EGFR has reduced, that's when you can be able to correlate it like that. But the normal value is above 90, like that.
Yeah, tarudi. Kuna mwenye amekuja huko.
Thank you so much. Maybe if I can add something, they are graded from grade 1 to grade 5. So grade 1 is a normal GFR, which is above 90. Grade 2 should be between 60 to 89, which is a mild decrease in the kidney functions. Grade 3 is 30 to 59, moderate decrease in the kidney functions. Then grade 4, 15 to 29, which is a severe decrease in the kidney functions. And then grade 5, which is less than 15, signifies a kidney failure, or what is called end-stage renal failure.
Oh, disease, yeah.
Yeah, so according to your question, the question was, when using CKD API, what values can you say it's too high? So too high in relation, if too high to you means that too abnormal, then and a GFR of below 15% is abnormal.
Oh yeah,
I
yeah,
hope-
yeah. I get what you're saying. Yeah, yes,
I hope
yes.
I hope Manuel is answered now.
That's true.
Yeah. Then another question is from Omondi Frederick. Since proteinuria is likely to be found in pregnant women, can we say it's normal?
It's likely to be found. It's not supposed to be found. It is likely to be found because there is, gestational hypertension, yeah, or things to do with the blood pressure that are just or eclampsia, those kinds of conditions. So proteinuria is used in assessment of those. It is not normal. Not supposed to find it. Although maybe if you can find maybe traces of protein because of the nature of pregnancy and what it does to the body, but not too much of it because it indicates that there is a problem, mostly in blood pressure control in those particular population of patients.
Thank you. Another question from Joy Mwendwa. Joy is asking, kindly state again the correlation between hyperthyroidism and kidney tests.
Okay, I talked about parathyroidism or parathyroid hormone, yeah, not thyroid hormones. So parathyroid hormone is PTH, and it is produced from the parathyroid glands, yeah, and it controls metabolism of these ions, especially calcium, phosphorus, magnesium, those ones. And it works with the negative and positive feedback. So if there is too much calcium, then this calcium is going to give a feedback to the brain, which is going to work on the parathyroid hormone, gets created, and now the bones are going to be affected by high calcium levels, which is going to be deposited into those particular bones. There is little calcium in circulation. Again, another feedback mechanism is going to go to the brain, and then a feedback to the parathyroid gland to secrete PTH, which is going to affect the bone resorption or resorption to release calcium to try to compensate on the low calcium levels in the system. So PTH is related to those particular ions in that particular axis or feedback mechanism, depending on the level of calcium, which is now the stimulation or maybe how can I put it? Yeah, the stimulus for the different PTH values.
Thank you so much. Manuel is still asking, does it mean GFR of let's say 100 of let's say greater than 300 is still normal?
I have not seen one like that, but I don't know whether maybe I don't know whether Fanuel has seen one like that, but mostly you'll not find so high EGFR values. But when it is above 90, then it is normal. But I've not seen one which goes up to 300. Perhaps we can be able to look into it. But when it is above 90, it is normal. I don't want to comment on how high.
Yeah, that's why GFR should be calculated for, especially using the formula AP. It should be done for people above 18 years. So rarely will you find someone who is above 18 years with a higher GFR of 300. Because if you try doing the formula, unless you say that person who is above 18 years has got creatinine of 30 or of 25, which again, that is very, very abnormal. So my reaction to it is that if you find a GFR of above 300, then it means probably one is that is a false high value. That is a very false high value. And it may be because there is a very high muscle wasting in that patient. or you probably used the wrong formula, or that sample you used, the serum sample you used, maybe you can do a repeat of it so that it can give you a reasonable creatinine value. Because above 300 with GFR or above 300, that means the patient has got a creatinine of 20, 25, which again may be a very false result. Thank you.
Yeah, thank you so much for that.
Yeah, Lilian Ouma is asking, why is low calcium and vitamin D related to most patients with renal failure?
Just to put it as a blanket, vitamin D is also controlled by the kidneys, and it's directly affects the integrity of the bones. And the integrity of bones depend on the calcium levels, right? So just to put it under that, all these things are interrelated because they are affecting, the target organ there, or the target site is the bone. And vitamin D, the higher the vitamin D level, the healthier the bones. And also, the healthier the bones. And the healthier the bones, the higher the calcium content of those particular bones. So when there is too little calcium, then those bones are going to be resorbed. And probably it's a reaction to maybe an inadequate PTH or inadequate vitamin D values in the system. So any imbalance now can be able to destabilize that homeostasis that exists between the two. And the bone is at the center of it all right, where the homeostasis actually happens, which will control the resorption or the integration of calcium into the bone, depending on the levels that are available in circulation. Yeah.
Thank you so much. All right. I'm not seeing any other question. I'm only seeing some comments. Maybe if there's any attendee who would like to speak, we can give him the rights to speak. Yeah, to ask any question. But another question from Rogers Cherono: why is potassium important in renal function tests than other electrolytes?
Bruce, please pardon the question.
Rogers Cherono is asking, why is potassium important in renal function tests than the other electrolytes?
Okay.
Hello, Baraza, are you able to hear me?
Yeah. I can hear you. So potassium has a very narrow window of, or level, maybe a narrow level of control. I mean, narrow levels, it's supposed to be between 3.5 to around 5.5. Now, it is also involved in other functions of the body, like the control of cardiac action or cardiac activity, control of nerve impulse transmission. So if potassium is low, sodium will be affected by the values are critical when it's less than 120 there, which you can rarely reach there. But potassium, you can easily reach a value of 6, which is already critical, or a value of 3, that's already critical for potassium. So it's supposed to be maintained at a narrow margin of control because it is involved in the sensitive action of the muscles, the heart muscles. So if there is too much of it, then it's going to affect the rhythmic contraction of the muscles of the heart, and someone can have acute cardiac failure because of too much potassium in the system. That's why it needs to be controlled, and that's why maybe biasly speaking, it is one of the best electrolytes to be measured. But all the others are equally important as far as body electrolyte homeostasis is concerned, including sodium, because it also affects other parts of the systems. But for potassium specifically, nerve impulse transmission and cardiac activity, those are greatly affected, and that's why it's supposed to be controlled in those particular cases of those patients. from those conditions. Yeah.
Thank you so much. 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 Thank you Okay, some questions here. Yes, they are topics of discussion. Not necessarily the speaker to answer them, but even if any attendee has got an answer to it, you can just raise your hand. We can give you the chance and speak.
Yes,
So
yes.
Veronica Ndolo is asking, what might be the issue when a newborn can't produce serum? Okay, client with HB, maybe the newborn has a HB of 24.9. Okay, HCT of 65.5, and not able to obtain serum for UECs.
But you can, Bruce, you can already see those values, eh?
Yeah.
And we know the components of blood. Blood's supposed to be around 45% RBC or hematocrit. Supposed to be around some, I don't know, 55% or what. That is the remaining one, plasma, right?
Yeah.
So if it is going above for 65,
65.5.
yeah, then almost the entire thing is red blood cell. So that's why you even if you have this sample has been put somewhere to clot, and newborns are usually like that because the HB is usually very high in those particular kids. So even if you centrifuge, I've seen this one several times, you might need a very large volume of sample to get a substantial serum for you to run your tests because of the nature in which it is. Hematocrit of 65 means that there is too much RBCs as compared to other components of the blood. But perhaps if there is another person with an input on the same, the flow is open. Someone can still bring in the inputs. Thank you.
Exactly. Stephen Mwangi has asked a question, and I can see Dan Odhiambo has answered him. Stephen asked, in the lab, which is the best to use as a measurement, urea alone or BUN? BUN is blood urea nitrogen. So Dan Odhiambo has answered, we use urea, but in fact, if you want to use BUN, that is blood urea nitrogen, you have a formula which is urea times 0.47. Any other input, Baraza?
Yeah, that is it. I think the slide on BAN really explained on that, where you just multiply by 0.47 to get your BAN. And then you can be able to release the report. I think that is it. It also depends on it depends on the urea levels anyway.
Thank you. And Dominic, on the same question, Dominic is asking, what is the difference between BUN and urea?
Blood urea nitrogen, it's you see, these are nitrogenous compounds that are broken down, from the liver and excreted in the kidneys. So the urea is already I don't know how I can be able to put it. Urea is already metabolized through ammonia in that particular reaction to give us the waste product that's actually excretable directly at the glomerulus into the urine as a waste product. But blood urea nitrogen tries to give us an average, better measure of how much urea concentration is in the blood. That constant has been derived with the input of other factors that can be able to give us a better measure of the actual urea content in the blood as compared to urea only, because it is a correction kind of matrix, because urea is excreted and it's also reabsorbed in the kidney. So those kind of factors affect the actual value of urea. So the correction formula, which uses the constant 0.47, tries to correct those ones so that it can give us an ideal value of actually indicating how much of urea is actually in the blood and help in monitoring the disease progression in those patients affected. Yeah.
Thank you so much, Baraza. So we have come to the end of today's webinar, and I want to thank all the participants who managed to join in for that discussion. And I also want to take this opportunity on behalf of LMSK to thank our speaker, Baraza, who has been very instrumental in these webinars. So thank you so much, Baraza. I just want to make a few announcements. That this webinar will attract 3 CPD points, which will be credited in the next 24 hours. There will be also a recorded version of it that will be accessible till the following day at noon. Then lastly, is that LMSK is planning to have a gala dinner on 28th of November this year at Pride in Westlands Hotel. So it is open for members of LMSK. It is a free dinner. The registration is free for members, but for non-members, you can pay a fee of 3,500 per plate. The dinner will start from 6 p.m. till late or till midnight. So that is the announcements tonight. You can visit our website for more information and to have a contact to reach out to. Otherwise, your last remarks, Mr. Speaker. Baraza?
Yeah, I can hear you. I think thanks so much for the interactive session. I think this is one of the most interactive sessions with a lot of questions and clarifications. And it means that people actually, we are all learning daily. And as I usually say, pick up those roles, make yourself visible in the healthcare team in your institutions, and perhaps you can increase the utility of laboratory medicine in our healthcare as a service provision. Thank you so much, and have a good evening.
Have a good evening too, Baraza, and see you members on Monday for another webinar at 3 p.m.